Hey, take it away.
Thank you. All right. Well, so I'm Debbie. Thanks for the introduction, Francis. Looking forward to being here. We're going to talk a bit about, as Francis said, documentation standards that we've done in AHS to get ready for our Connect Care implementation. Our Connect Care implementation, and you've probably all heard about it, it's been ongoing since about 2019, where we actually implemented in the fall at one of our largest sites in Alberta, which was the University of Alberta Hospital, and then all the kind of surrounding buildings, you know, the Mazankowski and the Stollery for Children's. It was 2 years of preparatory work to get us to the point where we were going to launch, and we'll talk a bit about that because that's where a lot of our standards and our content was developed for the launch. The scope of Connect Care, we're going to be running this project up to the end of 2024, and it will be felt everywhere. It'll be felt in community, it'll be in the inpatient environments, ambulatory, so the acute space, it's in continuing care. We will be in primary care a little bit, where we've had some legacy electronic health records within the primary care space. And also we'll be in population and public health. So we're really going to be everywhere. We'll be birth to death. We'll be in all clinical specialties that you can imagine, and we'll also be hitting other areas, corporate areas. There's billing, there's human resources, there's payroll. So all aspects and areas of our organization will feel Connect Care. And I guess at the end of this, when we are done, we will have over 125,000 users on the system. So that's very exciting. It'll be AHS and all of its affiliates. And so it's quite a large project. I don't know, Rob, is there anything you want to add to that, kind of describing Connect Care?
No, I think that's great. I think we are very thrilled to have just completed our 4th launch, and we're rapidly approaching our 3rd year of being live. Because the scope is so very large, encompassing a wide geographic area, but also a great deal of complexity and across the continuum of care in so many different systems, it's not something that you do overnight. But the pandemic did cause us to have a bit of a pause, and we're compensating for that, not by lengthening the project, but by compressing the remainder of the launches. I think we feel really encouraged because this 4th launch has actually gone much better than we'd imagined. We've been able to stand down a lot of our launch change management initiatives and supports much sooner than imagined. And I think it just speaks to, once things start to form a pattern that works, then it's much easier to take that pattern and implement it rather than something de novo.
Excellent.
Okay, and I think our plan was that I was then going to take the next part of the presentation, and then I'll hand back to Debbie. So my name is Rob Hayward, and thank you very much for the kind introduction, Francis, which is more than enough. For the purposes of today, so that we can preserve as much time as possible for discussion, what I wanted to do is take a little bit of a deep dive into an area that 1.5 to 2 years in, we realized that we were having challenges with our implementation. Post-implementation, we were having challenges with what's frequently called meaningful use. And we were starting to experience some of the things that, as you well know, have been famously emphasized by folks like Atul Gawande, why doctors hate their computers. And we were starting to also get a little bit of pushback about some things that were happening in that first couple of years post-launch. One of the biggest ones was concern about whether this incredible new health information system with so many powerful documentation supports was, rather than increasing the signal to noise ratio for clinicians trying to get their work done, might even in some ways be muddying the waters and making it difficult to discern the clinically important details. And that challenge, which is very much a challenge of a paradigm shift from, in our case, a paper to a digital environment, often gets crystallized in what people call note bloat. And we were starting to see a very significant note bloat problem. And so what I'd like to do is to tell you about that, tell you how we decided to address that in a systematic, multi-year way, and some of the early dividends that are now starting to pay. Why we've chosen that as a case example is because it was informed by decisions, standards, and norms that were developed, validated, and adopted before our very first person launched. But then in the light of experience and people learning and then maybe struggling a little bit to use the system, we needed to go back to those norms and find ways to facilitate their implementation by providing busy clinicians with practical, easy to use tools that would generate the kind of documentation that they could still recognize and like, while almost without their realizing it. So by stealth, implementing the standards that we really care about. So that's the spirit, and I'm going to share my screen and stop my video. And I just want to confirm that that's coming through.
Yes, it is.
Yes.
Okay, so again, this is a little bit of a case study within the big case study. And I know that Debbie's going to then go back out and take a look a little bit more at those standards later. So this is just about a very specific problem and how we decided to grapple with it. So my objectives are to review progress with a post-launch improvement initiative that was very dependent upon norms and standards in the area of clinical documentation. Doesn't get quite to the level of detail of terminology, but you'll see that a lot of the advanced work that we did about taxonomies, terminologies, style guides, and so on gets expressed through this. And one of the things we're especially excited about that clinicians are expressing a lot of satisfaction with is an approach that we chose to call interactive documentation that allows clinicians way that looks unstructured. They get a prose-friendly result that feels very familiar to them, like the kinds of letters they like to dictate, but has embedded within it structured content that helps us to achieve our quality improvement and reporting goals. So I'll just go through a little bit about the context and what we experience NoteBloat to be, and then how we structured a systematic multi-year initiative to deal with that, knowing that it is almost a universal problem with digital health records, and we weren't going to be able to solve it overnight. We'll talk about then, I tried to pick out things that would be more relevant to standards, and especially standards in terminology. And so we'll talk about building blocks that needed to express decisions we made about what needed to be consistent in documentation. And then I'll say a little bit more about the user experience, which again, we try to help them not even know that they're using the standards through interactive charting supports. So I think most of us have read about NoteBloat in one fashion or another, but just to remind you, it's a phenomena that emerges in digital health records such that clinical documentation paradoxically becomes more difficult and more time-consuming to read. It can be cluttered by inconsistent and inappropriate use of text, tables, lists, fonts, and styles that leads to what we call cognitive dissonance, as people are trying
Rob, I think we lost you there. Is it just me, Debbie?
No, I was wondering that too. I think we did lose you. Maybe
We'll give Rob a minute to recover.
Rob, are you there? Oh, he's out.
Yeah, he dropped off. He'll log back in. So sorry about that, folks. Please give him a moment to log back in.
There he is.
Hi there. We are having a major electrical storm here right now. So I briefly lost my internet. Am I back again now?
Yes, you are.
Sorry about that.
Oh, that's okay. Thank you.
Do you know how far I got?
You were halfway down this NoteBloat slide.
Okay. Then I won't overstate the obvious. I think we appreciate that NoteBloat also is a phenomenon that frustrates our attempts to use artificial intelligence enhanced searching, to use natural language processing, because a lot of replicated, copy-pasted text confuses artificial intelligence interpretation engines, which often look at things like frequency of concepts and so on. And it also, note bloat, makes it more and more clumsy and difficult to interface with other health information systems. ConnectCare in Alberta actually interfaces with something we call NetCare. And we were starting to get complaints from NetCare as a customer information system about a perceived degradation of the quality of the discharge summaries and other documentation coming out of ConnectCare. So this is something that is an almost universal experience, and it kind of reflects people bringing paper habits to a digital healthcare documentation environment. And the automated tools, a digital record, can actually really accentuate tendencies that we have in the paper world, where we feel that we need to pull it together and make data available, as opposed to really emphasizing data interpretation and analysis. So the liberation that the health record gives us is that we can be interpreters. We can be true health information executives rather than clerks, and shift from documenting the what to documenting the why, because the what is everywhere in the record and very easy to find. It's bizarre that people fill their notes with copies of lab results that are right there on another tab. And so the huge opportunity of a digital record is to bring thinking to the foreground rather than to have it obscured in the background. But if people don't realize that and change their actual behaviors, you get the opposite of the promise. Very interestingly, there may even be a little bit of a generation gap phenomena going on as well. We can talk about that more in the discussion if you're interested, but we see variance in perceptions of documentation quality and what folks are looking at, depending upon which side of about 35 you are. So that's what note bloat is. And we were getting anecdotal reports that we were experiencing note bloat, and it was causing frustration, especially for experienced clinicians. And so we first of all needed to figure out, is this really happening with us? And to figure out what the contributing causes might be, so that we could take those apart and have a programmatic approach to trying to deal with the causes. And so I'm going to talk about that next, and then we'll look at what we did on the standard side and then what we did on a user interface side. So we found, by taking a look at our own documentation, and I'll highlight some of the tools we were able to take advantage of, and that's the real good news, is that when you move to a high quality digital documentation environment, you simultaneously get a wealth of documentation exploration, automated analysis tools that can give you a real sense of what it is that's contributing to note bloat in your environment. And we found that the three biggest contributors when we did our qualitative analysis was what we would call mistuned tokens. So these are those text automation tools where you can put a little token in your letter or your progress note, and it will pull in something as simple as the birth date, something as complex as a care path summary. And we found that what came out of so-called foundation, what came from the vendor that we thought would be a tried and true product of working with countless other clients, in fact was pretty rough and needed a lot of additional work to reflect the way we do things in Canada and in Alberta specifically. So we found that these tokens that people were using were not adapted to different documentation contexts, such as when you're pulling in a problem list, the way in which you want that displayed is quite different in a admitting history and physical versus a progress note versus a discharge summary. And people were just using these things without discrimination. Things as simple as dates and the way they're formatted. Different tokens were using different formats. It was just mind-blowing. We thought we'd standardized all of that, but out in the wild, users weren't using the tokens that we had created as an Alberta standard. They were out there picking from anything they could find, and it was causing a mess, as you'll see. As many jurisdictions have reported, there is just a huge temptation to copy, paste, and copy forward. If you can get your progress note done by copying yesterday's note and tweaking a few new words, that's lovely. It really saves you a lot of time. And almost instantaneously, without any kind of guidance or suggestion, as soon as trainees in particular discover copy-paste, they tend to use it almost universally. And that is a major contributor to note bloat. And then misplaced documentation, not understanding. And it's hard to train people to do this because there's only so much people can absorb, but not appreciating what the purpose or the power of a particular tool is. So for example, in the inpatient setting, we have a tool called the hospital course, which is very wiki-like in its functionality. You start it at admission, everyone can contribute to it. It is the shared story for the patient of what happened during that encounter, but it was being used in bizarre ways by users. And instead, folks were often doing that wiki-type behavior in a progress note that got copied forward from day to day and ended up with major clutter in the chart. So we know we were satisfied qualitatively that we had a problem, and we could see some of the roots of that problem by taking a look at documentation. So we said, this is big enough of a potential problem if we don't get on top of it, that we will talk to some other jurisdictions, we'll look at the literature, and the most resounding message that we got from the experience of others is, you're not going to fix this by just reflexive reaction to a few problems. You need a systematic multi-year approach. So we knew from the experience of others that we needed to make sure that we had appropriate oversight in place, that it would be an organizational priority, would have executive backing, we would get resources that we would need to do it right, that we would have not only the norms, but the organizational commitment to endorse and support those norms, and that our end user populations who don't necessarily consider themselves always employees of the organization had the will to move to compliance with those norms, and that there would be multiple incentives to do so. And so we work with the college, the Royal College, College of Family Physicians, the local provincial groups, the medical association, our primary care networks. We just work with a whole bunch of folks. We then needed to actually overhaul the building blocks and the final templates that would be promoted, come up with new ways of training and doing just-in-time orientation to the new tools, and then have an intervention that would extend over many months or years and would be attuned to people who are brand new, that are launching, but then also people that are finally waking up to the need and opportunity for optimization, maybe 1 to 2 years into their journey. So the programmatic approach and the oversight was relatively easy because Connect Care already had great oversight groups. We were able to make this a top priority for a clinical documentation committee endorsed by the organization. And we could then move forward with the creation of some task groups that would focus in on the work that needed to be done in 6-month phases. Okay, a little bit about the norms. This we heard very loudly from others. You don't fix note bloat through tools. It's a cultural problem, and so you better have some way of tapping into the culture and slowly trying to reshape it and to shape understanding. So we had invested a great deal of time in our documentation norms, which are publicly available, and I'll give you a link at the end that you'll be able to use to review those. We really invested years of work into those, and we very purposely did not call them policies or procedures or standards. We called them norms because we wanted them to be understood a bit like good manners or etiquette, the things you need to do in order not to become a burden to your colleagues and your buddies, and in order to be a safe and a fair contributor to what is in fact a shared record. So those norms then went right into detail about all the little things that we found were contributing to note bloat, including copy paste, copy forward, and so on. I won't say anything more about them, but they're freely available to you. We post-launch, 1.5, 2 years in, went back to those norms, revisited them, said, are they realistic? What do we care about the most? And then we updated and tweaked them. We then wanted to get a sense of what's really going on. Qualitative impression is not good enough. We need some numbers. So we took advantage of the power of the system to develop some audit feedback and trending tools. And this is where things really get exciting. Our vendor was able to work with us to help produce some dashboards and some reports and some displays that allowed us in some cases to dig very deep. We could go down to individual users and look at their copy paste rate, how much of their material was original, how much of it was attributed, where it came from, whether people were using templates, whether they were using text automation tools, which tools were they using? Were they using the provincial standards? Were they using other things? How did that vary by different specialty groups? Where were there problems and so on? I won't go into the details. These are just some screenshots from some of those tools. And to cut to the chase, we definitely, from a quantitative perspective, had a growing problem. And that growing problem quantitatively, we were able to then find and pull out some of the most egregious examples of note bloat that was causing frustration. This is just one of them. I've kind of anonymized it. This is a progress note that extended to 14 pages in length when it was actually printed out. And I'm going to highlight a couple of things. Things like date, date of birth, universal identifier, common demographics, the things that we had set out to be standards. People were actually using some text automations that were pulling in different formats and not adhering to our provincial standard that was an unambiguous date format and all the other standards. So that kind of shocked us. Different fonts being used in different ways to signify different things. So you've got sometimes the bold font indicating normal or abnormal, sometimes it's a subheading, sometimes it's underlined, sometimes it's not. There was no clear conceptual hierarchy that was reflected in stylistic elements. So basically, our style guides hadn't been followed at all. In summative documentation, we had said that there needed to be headings that were always followed, always labeled the same way, always in the same order, but each specialty could customize within those headings. And yet what came out in the wild was very far from what we had actually said we wanted. There were also inconsistent use of abbreviations. And when you put all of these things together, all of this variance, and for example, use of very inefficient tabular displays where the information could be indicated in a more prose-friendly format, or it's in one place and duplicated in prose in another place, we basically ended up with, it was mind-blowingly obvious that we were on our way to serious note bloat if we didn't get a handle on this. So first of all, we said, phase one, we got to fix those building blocks. We got to narrow them down, and we've got to have provincially certified building blocks that we then start to find people who aren't using them and push them towards the provincial standards. And so examples of what we mean is, for example, if you've got a problem list, it has to be ordered, it has to have subheadings, and the fonts have to be prose friendly. So you can see for each thing like medications, problem list, we move to a prose friendly, clinician friendly form that when displayed was in the way that clinicians usually read things, so they wouldn't experience cognitive dissonance. And so, for example, if you're displaying meds, they're always in alphabetical order, which helps clinicians to compare, say, home meds to hospital meds and see where the differences are. We looked at every single automation that was used frequently, and we had data on that. And we went in and we made sure that those were corrected for actual errors or mistakes, and then we would promote people to move towards the new standards. We did develop that standardized structure for progress and for summative documentation such as discharge summaries, consults, and histories and physicals, operative notes, and so on. And we then developed templates that use the building blocks with all of the standards and would pull in structured data but make it look like it was dictated, and then also allow for easy dictation where prose was appropriate and structured data would not be needed. Okay, so all the building block work got done, but then how could you entice clinicians to actually use this? When you're dealing with a very powerful and sophisticated digital health record, you're intimidated very quickly as a busy clinician who's never been trained to do this. So you're trying to learn on the fly. It's the biggest paradigm shift in your career, but you get next to no time set aside to navigate that paradigm shift. And so we needed to find a way to entice people in to better use of standards and structured data. And we said, well, our starting point can't be all of the stuff that EPIC kind of promotes in their navigators and their activities and their forms. we say the starting point has to be the finished product. Why don't we present prose to the clinician and invite them to be able to click on that prose? And by clicking on it, they get just in time, small, manageable pop-ups that let them make a few point and click edits, and then the prose changes to shape those edits. The prose is there, the structured data is embedded in it, but no one knows it's there. And then when that actually goes out to other systems, it also looks like the familiar consultant's letter in a standardized format that folks had come to support. So I'll actually skip the principles. We're running out of time. What that meant is, here's an example. Here is a standardized little, we call it the presentation. And that appears as soon as you start your hospital course. So your hospital course started out for you so you can kind of see, oh, that's not a blank slate. That's what that's for. And I just need to start adding into the bullets the major milestones of what happened. But the new user interaction is, we built a lot of this. We sort of invented this from some brand new tools the vendor was bringing out that hadn't been in training or anything before. And so we made it so that anytime you see a different color of text, you could click on it, these pop-ups would appear, and that would then set up your prose to look a little bit different with what you wanted. And all of the buttons, the structured data, would be labeled in a way that would fill in your sentences the way you want. We also created an entire new set of tools that we called the physician sidebar. And this was, as you can see again in that, we signal to the clinicians, you get interactive charting wherever you see dark blue. So this then was a whole new way of experiencing the chart, where they could click on things and see the key information displayed in pop-ups or just in time or right within their documentation. So you don't leave your note to find something to bring into your note. And we made our provincial templates for documentation something that, again, you didn't need to remember the name of it. You didn't need to initiate it. If you wanted to have a full problem-oriented charting variant of a discharge summary, you just click on that, and then it creates it in the correct format. Where folks were maybe used to what are called navigators and activities, we then went in and we would substitute the provincial standards for the default. So people, again, didn't have to know about the standard. It would just be there in their face, inviting them to use it. And we adopted something we call Build Your Own Journey, where for things like a subjective or an objective note, you would pick from lists, and that would then build your prose note, but allow you to sometimes have something that's incredibly simple. And sometimes when life is complex, you could pull in as much detail in your vitals or your physical signs, your investigation as you want, and you wouldn't have to dig around in the chart. This would then automatically be pulled in depending upon the your answers to the questions. Okay, so the interactive charting was what we showed users. The behind the scene, new building blocks and new ways of using problem-oriented charting, we wouldn't really talk about, but that would be the implementation of standards by Stealth. And I don't want to take more time than I was planning, so I'll just skip ahead and summarize by where we're at. So we beavered away for an entire year building this, and we decided to take a lot of time so that we could involve stakeholders who are outside Connect Care. We created a provincial work group that included the Medical Association, representatives of primary care, basically the folks who read the documentation, as well as the folks who produce that documentation to devise the approach. We soft launched late in 2021, and a soft launch is where we don't heavily promote it, but we have early adopters who use the tools. That was incredibly informative and exactly the right thing to do, because we thought we had developed something fabulous, but out there on the front lines were all kinds of little issues that were discovered. And so we went through a period of many months of iteratively fixing what was discovered to be maybe not as slick as we thought in soft launch. And we're now on the eve of our full launch. We've just done a major deployment in Edmonton and Calgary, our fourth wave. And now, and the Calgary group were very, very keen to adopt this from the get-go. And now we are bringing this to the attention of everyone else who had launched previously and starting to promote it through training tools, usage surveillance, dashboard feedback on quality of documentation. So we've got a full loop that can be closed. Folks can see how close their documentation is getting to college standards, to norms. They actually get reports on how often they are using things like copy paste to advantage or not. And then they've got access to the tools to adopt and use to improve the quality of their documentation. And they can see that reflected in the feedback that they get. And with that, I'll conclude and hand over to you, Deb.
Excellent. Thanks, Rob. All right. Share screen. Sorry, I didn't even look for this. Where do we share the screen? Share screen. Okay, can everybody see that?
Yes, we can.
Excellent. Okay, so I'm actually going to
Your screen's got the two
how's that?
view. Yeah.
Did that? Okay.
Yeah, now it's good.
I'll reinforce some of the concepts Rob did, and I'll probably take us a bit back to the beginning of our journey with designing our documentation, as Rob talked about. And then also, this will be from the nursing lens, but a lot of it bleeds over into the multidisciplinary team. So this slide I went through, this is just the scope of AHS. And you know what, we'll send our presentations out and you can see that this is our timelines leading us into 2024. This, though, I wanted to talk about when you start to look at developing content and standards and documentation and other things in our electronic health record, we really did have to think of how providers will use the system from each one of these kind of layers, if you like. A lot of thought had to go into standardizing common language and even vocabulary from, allergies and how do you do MedRec and what goes into that, assessments, progress notes, as Rob talked about, the notes and then redesigning them again when you realized you had some note bloat. And so a lot of thought went into this. And some of our goals as we went and started up as Rob talked about, the documentation committees was around reducing the burden and eliminate duplication. We often had that mantra at many of our groups. We wanted evidence-informed best practice built into our documentation. You have to adhere to your professional and regulatory requirements. And it was a great opportunity for all disciplines to look at incorporating decision supports into documentation. We wanted to look at standardized vocabulary across all care settings if you can. So it wasn't about long-term care having their own set of, documentation tools in the electronic health record and acute care having their, and ambulatory doing their own thing. We looked at standardized enterprise documentation, and I'll talk about that. And then feeding on that is scale scores and tools. We wanted to really reinforce you document falls in one way, you document pressure ulcers in one way across the continuum with all care providers, and did a lot of work to standardize that. We used core set of standards and then layered on specialty. And then we really wanted to support some of our bigger AHS initiatives, such as our collaborative care program, and then our patient and family-centered care, always thinking about the patient and the family with this. Rob mentioned this a bit, and I'll just point this out. We did develop for governance and nursing content standards practice work group. We had an allied health group, and we had a physicians group, the clinical documentation committee that we all reported into and tried to standardize amongst all the disciplines was the ClinDoc committee that Rob had mentioned. This was really looking at core content and talking about how do we all work together in the electronic health record, because it is one shared record between providers. We also had to consider how you layer on specialty content, and we have area councils for that. And if you ever want to talk about governance, just let me know, because we've got a lot of experience here. Nursing content standards work group, though, we started this in April of 2018. We had approximately 50 nurses across all specialties, including our RNs, RPNs, and LPNs. We set a meeting time every Tuesday. We met for years, and we're still meeting into 2022 every Tuesday, because it, like Rob said, it requires a lot of work when you start to get into that documentation quality and the improvements that are needed. We had many partners involved in our work, our e-safety group, we had human factors, IT, professional associations, professional practice groups, we had experts in clinical content, and we had strong nursing leadership in our group. We had some working principles, learn by doing, be humble and improve, because this was our first time that nursing as a discipline, if you like, across AHS was coming together to do something this large, right? We all had our pockets of standards and we all had our pockets of documentation, but this time it was, you know, kind of park what you've done and let's look at what we're going to do into the future. We knew we needed to always align to strategic direction, you know, our quality and safety, our choosing wisely initiatives, anything that was going on in the organization, want to always support innovation. This was a great opportunity for us to think about what are decision supports for nursing in the system, and then how do you support inquiry and self-reflection of practice? This is something that we had as a goal. We didn't really capitalize or achieve the goal of getting the right reporting in place to kind of give back what documentation is telling you, but it's something we're still improving upon. We want to improve nurses with their own data about their practice and give them the information they need to improve. And then, yeah, refining any outcomes measurement strategies. You always got to be thinking about what are the outcomes you're looking to improve? How do you measure that? So I think the last three is something we're still working on, and probably would be moved into that improvement bucket as we go forward, an optimization bucket. We'll just go through what we did. We came together and you've got three kind of groupings of documentation for most disciplines. You look at admissions, you look at your daily cares, and then you look at your discharge or your transition processes. And so for admission screenings, our ClinDoc committee did a lot of work to document, standardize, like things like our falls, risks, and the tools we use across the continuum. We looked at pressure ulcers and suicide, got the Columbia implemented across the continuum of care for all of our clinical specialties. We looked at standardized tobacco, alcohol, substance, domestic violence, ARO screening, and values and beliefs. And this is not just for nursing. These are shared kind of documentation pieces that could cross into the physician arena and into the allied health perspectives. And so we really tried to think of how do you set a standards that all disciplines can use. We are talking through, we did standardized discharge screenings, you know, what is needed. So discharge starts at admission. How do you start planning for that? And then spent numerous meetings and hours looking at COVID-19 identification and symptom monitoring as a collaborative group with our physicians, allied health professionals, IP&C leading the charge. So lots of work was done here. Physical assessments. For nursing, we did something unique to AHS. Like it's not unique in documentation standards, but it's a unique approach that AHS, a new approach maybe that AHS took upon, where we documented within defined limits for nursing. We came together as a nursing cohort in AHS and did standard definitions for systems. And then we said, if you're not within that standard definition, then you go in and you do some documentation. If you are, then it's within defined limits. And so again, we're really looking at reducing the burden of documentation. An example of that is neurological. I'll just show you here. It's within defined limits. This was our standard definition that, you know, they were alert and orientated, they had purposeful motor, open eyes spontaneously, they can communicate needs, and they follow commands. You'd be surprised that just getting these standards, these 5 bullets, probably took us, I don't know, weeks, but we got there and we had everybody involved in this. Now, if you're outside of that, you know, you would go in and then you would maybe document if they had some facial symmetry or left facial drooping, right? But if they were within it, you just said it was within the defined limits. And again, focusing on how to reduce that burden. This is a standard within all of our inpatient areas. It's included in our long-term care facilities. And anybody that uses that kind of inpatient documentation approach. So we're getting good data across specialties. when we get into our daily cares, we looked at our ins and outs and our vital signs. We did some predictive models that I'll speak to later, early warning systems and pediatric early warning systems. We talked about daily cares and incorporated our decision supports from many of our initiatives, things that our strategic clinical networks were doing. We looked at accreditation. We, anywhere that we had some AHS standards, we tried to adopt these and put them into our daily cares. What is our falls interventions that we need to be looking at, or comfort interventions from our collaborative care program? We looked at evidence-informed care plans. Now, this didn't work very well. We don't use them, so there's a lot of optimization. Care planning is an interesting conundrum in nursing because you learn it when you're going through university, and it's something you really focus on. But when you get into practice, our documentation standards or our tools were never set up for care planning. So it's something that we're looking at. How do we do this better in the system? And then how do we actually get care plans that are shared between allied health and nursing, and possibly physicians having, a view into this also. So lots of work being done there. For accreditation, we looked at standardized nursing handover and chose the iDraw, and that's also included in physician and allied health documentation. Patient and teaching discharge. So this was something where we did a lot of work on using a safe discharge checklist. Again, discharge starts at admission, and how do you start to plan for that? We have standardized patient teaching modules that are used across our acute care setting and into ambulatory and continuing care. A lot of these modules will link to what's called My Health Alberta, which is a Alberta website for patient information, and it's all standardized. It links into our patient portal, and it can be searched through terminologies and embedded into after visit summaries that can be given to the patients. So really did a lot of work around patient teaching, and then other patient support standardized our information that we provide to patients. What do we give them on their portals? We encourage patients, I'll give you an example. In Launch 4, all of our oncology patients are being signed up for the patient portal. And the cancer in our oncology, cancer control within AHS has really adopted the patient portal as a mechanism for communication with providers. And so all providers can document on the after visit summaries, including the nurse can comment on their care. Other aspects that we did look at were some nurse initiated protocols. We did the predictive analytics to start to look at deteriorating patients, early warning systems, and then also our sepsis models. And we're still kind of working on falls, hasn't quite been implemented. And then we really wanted to think about choosing wisely and other quality initiatives. We've achieved level 1 appropriateness within AHS. So that's wherever the Connect Care sites are. And we're also thinking in our nursing, arenas, what are the 9 things that nurses should question? That's choosing wisely. Should we start to thinking about, remove the tube? We know that urinary catheter infections can increase length of stay, cause all sorts of complications. And so how do we start to think about that in the future? Improving patient outcomes, I talked a bit about this, but Connect Care allows us as a multidisciplinary team, and the nurse being a part of that, to document patient goals, their preferences, and what matters to the patient in living and managing their health issues. We are able to take that information, assimilate it, and understand what kind of patient teaching and discharge materials that we need or could be giving to our patients. And I talked a bit about My Health Alberta website and our patient portal. And so I think this is for nursing anyway. This is a way that we can show our care through patient teaching and discharge. We can prepare patients as they leave. We are teamed up with physicians when we do rapid rounds and team care. So a lot of this, I think, is it's really innovative. And it includes the patient now through things like the portal or documents they receive. It includes them in their care. So really believe that this is going to lead us to patient outcomes. We haven't measured any of this yet. So, but even just implementing this functionality is moving us in the right direction. So 2 more slides here. So successes, we did incorporate evidence-informed best practice in our documentation, and Rob will attest the hours of discussion at our ClinDoc committees around scales and scores and different tools, and what is accreditation doing, and a lot of work came into that. We have reduced the burden through some of the work that we've done with nursing documentation. And I think if we haven't reduced it, we've organized it a bit. We're avoiding duplication where possible and aligning data collection with standard workflows. We're trying to move nurses away from less narrative and more data driven. It's interesting, it can take anywhere from 6 minutes to 12 minutes to write a nursing note when patients come in. And we're really trying to say, if it's in other forms of documentation, let's move away from the narrative. You can't measure it. It can't support our outcomes. And so let's start to do a blitz on that. That's one of the things we're looking at, is after we get out of this launch, is how do we start to support nurses and let them feel comfortable that they don't have to do the narrative. We did move clinicians to accept standardized measures, and we incorporated variants where needed. So if a tool didn't work, or you'll see that we had, I think it was 4 falls tools for assessments. Where it didn't work, we did look at some variants. Absolutely. We reinforce patient safety through our documentation and provide a point of care decision supports. We've done that in the area of falls and pressure ulcers. So for example, if they score high on a tool, then we have prompts to say, should you be consulting an OT or a PT or somebody else that can come in and assess the patient. We have standardized data sets to support self-reflection, but we just haven't pulled it out and provided it back in a meaningful way yet. Next step, so, as Rob said, lots of work. Rome wasn't built in a day. For our work, we need to look at building outcome strategies, looking at nurse satisfaction, adoption and uptake with what we've done. We want to evaluate the documentation and look at the nursing care. Did any of the decision supports we put into the system actually improve the way nurses document? Can we get some patient outcome measures out of that? And we want to, as Rob is doing, look at documentation data quality initiatives. This is exciting for us. This is the first time we as nurses have really dove in and done this type of work. And so, as a group, we're pretty proud and really are moving, I think, our whole discipline into the right direction. And, I'm also involved with allied health. It's kind of the same ideas with allied health. So I'll stop there.
Wow. First of all, let me stop the recording. And this is just phenomenal. I'm so impressed